Are you able to see my slide deck?
Yes, sir. Yes, sir. Yes, sir.
All right. Good evening, everybody. First of all, please let me know if I'm very clear and audible.
Yes, sir, you are clear and audible.
All right. Uh, First of all, let me thank the department for giving me this opportunity to interact with you today and share my little experience with pediatric laryngology with you guys. And I see it's a very august gathering, and I would like to keep it as interactive as possible so that at any point in time, if any of you have any doubts or any questions, you can interrupt me and we can take it in a short discussion format. But if it requires further explanation, I'll probably take it at the end of my talk. So with that kind of an introduction, let me introduce myself. My name is Dr. Srinivas Kishore, and I am the Director of ENT Services and Sleep Apnea Services at AIG Hospitals in Hyderabad. We at the department have different subunits, and we get a fair share of pediatric and neonatal work. So the title that I'm going to talk to you about today are two. One is I'm going to talk to you about laryngeal clefts, and two, I'm going to talk to you about webs, and that's the title that I gave, ma'am. So the title is going to be laryngeal clefts and webs. So the first, I'm going to talk to you about laryngeal clefts, and then I will talk to you about webs. So second. So what are laryngeal clefts? Laryngeal clefts are actually, unfortunately, a rare clinical occurrences, but nevertheless, we as ENT surgeons should know to pick it up when it's there. So by definition, laryngeal cleft is a congenital condition in which there is an abnormal communication between the larynx and the esophagus, because there is an opening in the posterior laryngotracheal wall, which basically is allowing food and liquids to pass from the esophageal lumen into the airway and hence causes aspiration. So as you can see in this introduction, you know what is happening and why and how these patients would present to us. Since it's a congenital condition, the babies would present pretty early based on the severity of the cleft. Now, here is a beautiful diagram very clearly describing the different types of laryngeal clefts. Initially, it has been the clinical system has been coined by Benjamin and Inglis. It's called the Benjamin and Inglis system. Now, there are four basic types of clefts: cleft type 1, type 2, type 3, and type 4. And each one of them are very clearly, you can make out that. Let me just show you. Now, this is type 1 cleft. Now, type 1 clefts are usually almost subclinical in their presentation. Unless there is an obvious problem, these kids don't present, and I will show you a video how difficult it is sometimes to differentiate it from laryngomalacia. A type 1 cleft is basically a cleft. It's a deep notch between the arytenoids, but the cricoid is perfectly intact. In type 2 clefts, you can see that the notch between the arytenoid or the interarytenoid notch is gone deeper. And here you can see that there is a defect in the posterior lamina of the cricoid cartilage. When this becomes further deeper, it can be called a 2B. That means if the cleft is involving the posterior wall of the cricoid up to the base of the cricoid, it can be called a 2B. A 2A is in between that means midway in the cricoid cartilage, and a 2B is to the base of the cricoid cartilage. Type 3 is a deep wedge, is a deep cleft bypassing the cricoids. That means the posterior wall of the cricoid is also defective, and so is the posterior wall of the membranous trachea. And type 4 are deep clefts extending right from the cricoid apex up to almost up to the level of the carina. And you can see here very beautifully there at the level of the thoracic inlet. This is going beyond the level of the thoracic inlet. Here it is not up to the level of the thoracic inlet, but it is way past the lower border of the cricoid cartilage. So I've put a picture here for you just to know the difference between a simple laryngomalacia and a type 1 cleft. How would you know? It's very difficult to know just clinically. You will have to put some kind of a probe to actually try and see and make a wedge between the in the interarytenoid space, insinuate this particular instrument so that you can actually see that there is a cleft. Now, I've also noted down a couple of syndromes here. These syndromes are the ones that usually manifest along with laryngeal clefts. This is something that is important for you postgraduates because these are some things that can come out as questions. So 2 take-home points in this particular slide. The system of classification, which is the Benjamin English system. The second thing is that you need to know the different types of laryngeal clefts. And number 3, you need to know the different syndromes that laryngeal clefts are associated with. And number 4, the most important point, how do you differentiate a type 1 laryngeal cleft or any laryngeal cleft from a bad laryngomalacia? It is through this a probe test wherein you can put in a metal probe, wherein you can actually put the probe. Can I continue?
Yes. Yes, sir. Yes, sir. Please continue.
Yeah. So the take-home points from this particular slide are these 4 points. Now, how do these kids present to us? They actually can present with a myriad of symptoms, but amongst them, the most common are cough, especially while feeding, recurrent respiratory tract infections. This is a symptom that type 1 clefts usually present with, because we won't be knowing child will have recurrent lower respiratory tract infections, and most of the time we'd be missing this because there is no obvious cleft. You wouldn't have that particular history of classical cough while feeding. They would, however, present with recurrent lower respiratory tract infections. And ignoring these recurrent lower respiratory tract infections, children may or babies may present with respiratory distress and frank aspiration. So type 1, type 3 and type 4 clefts are usually they present with swallowing dysfunctions, whereas type 2 clefts, because these are the clefts which are neither obvious nor they are too light. So these are the ones that present with stridor. So it's again very important, dear colleagues, junior colleagues, for you to understand that even though these 4 are the primary symptoms with which babies present to us as pediatric otolaryngologists, you need to know that which are the type of the clefts that present with swallowing dysfunctions and which are the clefts that present with stridor. So you need to understand that stridor doesn't necessarily mean only laryngomalacia or cord palsy or subglottic stenosis. Even cleft babies do present with stridor, especially the type 2 clefts. So in approximately 58 to 68% of patients with laryngeal clefts, there is often an other congenital malformation that is there. So whenever you see a laryngeal cleft, always look for another comorbidity that would present, because 58 to 68% is pretty high. Usually, these anomalies are in the gastrointestinal tract, like esophageal atresia, or tracheoesophageal fistula, or intestinal malnotations. So you don't have to look farther; they are in the vicinity. So when there is a child of laryngeal cleft, always look for associated problems in the GIT as well. And they are pretty high in incidence, about 58 to 68%. So here is a flexible laryngopharyngoscopy of a patient with let me play this. Are you able to see the video?
Yes, sir.
Are you able to see the video? Yeah. So let me just, this is on a flexible FLP that you can see that there is a notch here, and this is in rigid scopy. Very obviously, this is a type 2 cleft wherein you can very clearly see the defect. This baby is intubated because patient presented with severe distress, and you can see when I'm lifting the endotracheal tube up, and you can actually see the entire defect. There is a defect between the arytenoids. There's a deep wedge between the arytenoids. Now, how do you go about treating these patients? Usually, if it's a type 1 laryngeal cleft, injection of hyaluronic acid itself or Hylase injection is good enough. Injecting Hylase will give you pretty good sort of closure of that defect. And if the child is presenting with feeding difficulties, or if the child is presenting with recurrent cough, this simple injection will give a lot of relief to the patient. However, from type 2 clefts onwards, something has to be done. Just giving an injection will not be enough. You need to go ahead and do either an endoscopic repair or an open repair, basically based on the severity of the problem. So here is a video of a repair of one of the clefts. This is a type 2 repair. I have put it in fast forward so that it doesn't eat up into our time. This is into almost, so here I'll describe the video for you. I put a pledget. I'm using a coblation to create a raw area in the mucosa covering the arytenoids. And it is very important to release the arydioepiglottic folds as well, because when you do the surgical intervention, if you don't release the arydioepiglottic folds, it's very difficult to get that mucosa to close. So you can see that I'm using a simple laryngoscope, an anesthesia laryngoscope. So I've created a raw area between the arytenoid mucosa, and then I'm closing it with Vicryl sutures, or you can also use 4O PDS sutures. It is very, very important to start from inside out. And you can see how I'm going ahead and making multiple sutures. At least 2 sutures have to be made so that you will get adequate closure. Now I'm trying to put in a third closure as well. The most important point is that you should not be tightening the knot too much. So it is important that you close it, but tie the knot, but the knot should be snugly fit. So you can see how the defect, we have closed the defect And I'm using neuropathies here. And again, we don't want too much tension. That's why I release the aryepiglottic fold there. And now you can see the entire, see there is a bleeder there in the AE fold, which we completely closed. I'm also creating a raw area in the lingual surface of the epiglottis to create a glossoepiglottopexy. So this is another video. Again, this is in slow motion. You can see that we have created a raw area here. It's very difficult to suture in that area. So this video is for you to sort of understand what we did in fast forward there. And you would be also, you see the raw area and the aryepiglottic folds, because unless you release that, you will not be able to get a good closure. Okay, so my colleague is holding the laryngoscope, and I would take a bite, come out, and then, are you able to follow? Okay, let me just. And you can see how we are holding. This video is for you just to understand that. And this is a knot that I have put. Okay, and also I was telling you that the knot should not be too tight, so that because if the knot is too tight, the mucosa will get necrosed below and cause problems, right? Just to approximate, you can see the esophageal opening there, and this is how you tie the knot. This is the post-op image of how these babies heal beautifully. There, you can see, even though there's a little bit of as if there is some mucosa holding the arytenoids together, but yeah, the symptom relief is very dramatic. So there are certain pearls that I want to discuss with you. The most important is excessive force and inferior pressure in the posterior glottis may lead to incorrect diagnosis. So you shouldn't be putting too much force when you want to diagnose these clefts. Adequate endoscopic exposure of the cleft is vital for success. If exposure is limited, an open approach is any day better to do than an endoscopic approach and closure. It is of paramount importance to completely remove the mucosa at the apex of the cleft to prevent any kind of residual bridge of mucosa, because if there is any kind of a bridge of, if there is a mucosa that is left behind, then it won't heal properly. And the first suture is the most important suture, then that should be placed at the inferior extent of the cleft. And most importantly, while placing sutures, care must be taken not to inadvertently involve the mucosa or epiglottis, because again it can bleed and cause problems. This is as far as the clefts are concerned. I'll go through the webs also for you. Again, the classification by Cohen. This is type A, B, C, and D based on the extent of the larynx that is involved. Type 1, there is 30% of glottis, no subglottic extension. The treatment plan is observe, you don't have to operate. Type 2, 35 to 50% of glottis and subglottic extension is minimal. you can decide between surgery or observation. Type 3, 50 to 70% of glottic obstruction with very thick subglottic involvement. Definitely, you will need to do a surgery with a tracheostomy. Type 4, 75 to 100%, that also you will need to do surgery and tracheostomy. So here is a patient with laryngeal web. You can see beautifully the type 3 laryngeal web. And this is how we go about treating this. This is a microlaryngeal wand that we are going ahead and dividing it. There are different ways to do it. And if you remember, in type 3 webs, there is significant subglottic extension. So there is a subglottic extension which you have to remove. And this is how it is. So in these patients, this is an endoscopic and open approach. You can see that we have completely divided the web. And after the web is completely divided, it is important that you identify a small, like I said, this requires a tracheostomy, and we have done a tracheostomy for this baby. To identify the extent of the, see, you can put this needle, and once we put the needle, we know that whether we have dissected it exactly in the midline or no. And then you can see now that in this patient, we have put a keel, which is endoscopically and externally. It's a hybrid technique. The keel is the most important thing. Why we need the needle is we are using a knife to cut exactly put the keel. Yeah, so that's about it. Let me just, if there are any questions at this point, let me stop sharing. Are there any questions?
Yes. Sir, it was a very informative talk, and like the students, for them it is a new concept of cleft, and they are seeing it probably first time in the screen. And I think now when they will encounter that the endotracheal tube is going in esophagus, they will understand that this is a cleft they are dealing with. It's a beautiful thing. Yes, repair of it will be very tough. So videos of that we should watch more. And very thank you so much for joining. And it was our pleasure to. Thank you, sir. Thank you. Bye bye. So thank you.